workup, it doesn't change the therapies, it really doesn't change anything.
The next question is addressed to all three of the presenters. How does a physician of one gender approach a sexual history with a patient of the opposite gender without arousing, disturbing, or kind of difficult to read the next part? I think it's really just approaching sexual history in an individual of the opposite gender.
I think that's an excellent question. It really is just one step beyond the issue of just raising the issue of sexuality. And I think there's no way around, all of us, no matter how experienced we are, feeling some level of discomfort bringing up sexuality, which is maybe why we don't do a good job of it. I think if it's included as a routine part, the more you can routinize it as part of the history, the more it just seems to be part of the usual, initial history. In the review of systems, I think you can put it right in there with the genitourinary review of systems. And, people are worried, well, I don't have a good enough relationship with the patient to bring up an intimate subject. But I think a simple question, the first visit, are you sexually active? Yes or no? And, if yes, do you have any problems you'd like to bring up? If no, is that a problem for you? I mean, it can just be two simple questions to introduce the topic. And I think the more it's part of a routine intake history, the more we can overcome issues of gender difference or, lack of comfort with the subject. David, what's your experience with that? Well, you deal mostly with men, so
Yeah, mostly with men. But my experience is, I mean, that's part of my history. That's on every patient who comes into my office. I ask them that, whether they're coming in for a kidney stone or whether they're coming in for prostate cancer or other things. And I simply, when I get to that question, I ask them about erectile function. Do they have any questions, any problems? And then I ask them what their, is this something that you wish to pursue treatment for if they have any complaints. And sometimes a lot of times they'll say, let's deal with what's going on today and we'll handle that as soon as this issue is resolved. But I think most people, once they get comfortable, will open up and actually be very specific. Most patients are pretty specific to the point where, a lot, what they've tried. And people, I think, are, in my office, I found, I'm sure you find this also, they constantly will tell you whether they've tried with another partner, like you were saying, or whether they're very open. It's surprising how open people are in the office.
I was just going to say, one of the things I talk to people about asking, as you said, one first question is, are you sexually active, yes or no? And then the second question could be, do you have any concerns about your sexual functioning? Or if they have a medical illness, to just say, have you noticed any changes in your sexual functioning since the onset of your illness?
I would like to say I never ask anybody if they're sexually functioning. If they present me with a problem, I would say, does this problem get in the way of you having sex or having orgasms? I don't ever ask anybody if they masturbate. I say, how often do you masturbate? You can stun people, but if you tie it to a problem, it's usually easier to talk about it. So that's right.
Just a final comment. I think if you hesitate to ask because of concern that you may be offending the patient, you'll more often make a mistake. In other words, oh goodness, I'm getting lost in my semantics here, but if we don't ask, we're not going to find out the issues. So, you may at times make a patient uncomfortable. I always, when we talk about this subject, think of one of my favorite patients who's an elderly African-American gentleman, raised in the South, and he's been my patient for years, and he has severe heart disease and severe COPD, and for years he's had shortness of breath with intercourse, and every time I bring it up and try to counsel him about, cardiac and pulmonary, he's like, oh, Dr. Bloom, because, embarrassed that a woman is talking to him about this, but he really appreciates the fact that it has been addressed and that it's out there and, up front. So I think that initial level of discomfort is overcome quickly, and the person understands that you're really asking out of advocacy for them and their interests. Dr. Rodkey, who's in the audience, volunteered to make a few statements about testosterone use, and I really welcome that. Gay, can you? Here, go ahead.
I have just a quick comment on this last thing. Pfizer did an extensive survey on this business of asking and found out that most patients want to be asked and they're afraid to bring it up. I think Dave, as a younger urologist, is probably a little more active in terms of asking, but the average physician does not ask. According to the survey, and number two, the patients want to be asked.
I figured it might be helpful to say a few words about testosterone in women. I started out having a lot of experience with this since vulvovaginal disease is sort of what I'm known for. And I treat a lot of women who have lichen sclerosis and other similar vulvar problems. One of the treatments for lichen sclerosis has traditionally been topical testosterone therapy. And so I've certainly had experience using those drugs. And Oprah Winfrey boosted the popularity of topical testosterone a couple of years ago when she mentioned it on her show as one of the treatments or one of the things that people could do to get the ball rolling again. I think that it's nice to know that that's out there. It's certainly safe used in small quantities, a 1 or 2% preparation mixed in petrolatum. It may have as much of a placebo effect as anything else. It may give them permission to touch themselves. I tell them the massage is as important as the medication to improve the elasticity of the skin. It also gives them permission to do some stroking and to improve their excitation, to get their lubrication going. I tell the women that there really is a use it or lose it phenomenon, and if they're going to undergo a long dry spell, that it's very important for them to take care of themselves. If their husband is sick, one of the things I'll address, women come in and I say, how are you? And they say, well, my husband, he just had a heart attack or a stroke or whatever. It's really important to encourage them to take care of themselves, to make sure that they have an irregular orgasm, that they potentially use a dilator or a vibrator, because especially if they're not using hormone replacement therapy, a woman who has been quite sexually functional can become dysfunctional relatively quickly. She'll quit. I really think the absolute hormone level is less important than the sex organ that's above the collarbone, but I think that by drawing a free testosterone level, it gives you a chance to discuss where she really is. And if her level is very, very low, so you can use a little topical testosterone, and you can measure it again. It gives you a reason to bring her back in, to talk to her about these issues, to talk about other things she might try. If she's already high, then obviously this is not a woman you want to give this to. You'll want to concentrate perhaps on giving her a little more estrogen replacement if she needs that, because that'll improve her sex hormone binding globulin. And to the extent that unattractive to her changes in excess hair growth or changes in her thickness of her hair or whatever, to the extent that the hyperandrogenic changes are making her feel less sexual, you can help those things too. So I think that measuring testosterone levels is an important thing to do, just to give them permission. As far as oral goes, if they don't like touching themselves, which a lot of older women will, they've just been educated very much not to do that, Estratest, the half-strength one, is more than enough. Giving people permission. I tell them it's a little green pill, like your kids will tease you about the green M&Ms being aphrodisiacs. If they use the Estratest AHS, the half-strength, every other day, or Tuesday, Thursday, Saturday, or Friday, Saturday, Sunday, if that's when they tend to be sexual, instead of their Primin or their Senestin, if they're taking combination therapy, you just substitute it in for whichever estrogen preparation they're using, and I have them titrate it. Titrate it by how your libido is doing, titrate it by how you're feeling, but you don't want to just hand a woman an Estratest full-strength prescription when she says, my libido's not so good, and send her out the door, because if that's not what's bothering her, she'll get all the negative side effects of the testosterone, the hair thinning, the anger, the inappropriate emotions, the aggression. She'll get all those things, won't know what to do with them, and it may not help her sexuality at all. So I think it's really important to look at the whole patient rather than just jotting out the prescription when she first asks.
That's the male behavior.